Hi, everybody, and thank you to the meeting organizers for the opportunity to be here. I think earlier Natasha said that I was cool, which I thought was interesting because my 5 and my 7-year-old just over the weekend confirmed that I'm not cool. And the 7-year-old asked me yesterday when he found out I was coming here today, he said, "Why do you talk about hair when you don't have any?" And so, you know, that's a good question. Anyways, these are my disclosures. And it's fun to see what a graph of Janus kinase inhibitors and dermatology, just a PubMed search, looks like in the last little bit over a decade. And you see that really, in 2014 with the publication of oral tofacitinib for alopecia areata, and then a year later, vitiligo treated with tofacitinib and atopic dermatitis with tofacitinib. It's interesting to think that literally 7 years later, we are on the heels of FDA approval of JAK inhibitors for all three. Well, in fact, we just had topical Ruxo approved. So it's fun to see how rapidly things can change when there is science to support an observation. You know, this talk could be very expansive. These are all of the conditions for which JAK inhibitors are efficacious. Of course, or in this talk, I'm just going to talk about JAK inhibitors for atopic dermatitis and alopecia areata. And so diving into atopic dermatitis, so I think it's always useful, right, to not just make a random observation, but I think it's useful, right, when science tells us to go someplace and we go there and you know, the observation holds true. It makes even a case report very robust. And so, you know, when I was a resident, you know, we were learning about filaggrin, but really what we knew was that the histology of atopic dermatitis showed a predominantly T-cell infiltrate on H&E. And so what did we do to treat the disease? We used T-cell suppressants, just broad immune suppression. And then, of course, you have the work of Dr. Gutman and others, which help us develop, you know, a cartoon of the myriad cell types and the cytokines to explain what's happening in histology. And when you have that, you have the ability then to say, you know, I'm going to develop a molecule that targets IL-4 and IL-13, such as dupilumab, or IL-13 with tralokinumab or lebrikizumab. Or you can look at the myriad cytokines that are driving disease and make the observation that all of them signal through a pathway called the JAK-STAT pathway. And then if you have a JAK inhibitor, then you can bring that to bear on disease and see what happens. And of course, everybody in the room is familiar with this. This is, you know, an incredibly rich story. And this is, you know, up above JAK inhibitors that are FDA approved currently, none in dermatology in the US, but as you can see, baricitinib was approved in Europe a year ago, and upadacitinib just recently in Europe, abrocitinib just recently in Europe. And again, we're on the heels of these approvals, hopefully, in the US. And then just 4 weeks ago, ruxolitinib cream, or Opzelura, was FDA approved. So the first JAK inhibitor in dermatology is a topical. And then down here, these are, like I said, under investigation in the US. So let's dive in to atopic dermatitis first. And we'll restrict I'll restrict, you know, the data that we're going to talk about to data that's, you know, phase 2, phase 3, kind of the highest level possible. And so ruxolitinib, 1.5% cream. Again, I said that this was just recently FDA approved. But again, you know, really striking here we see that, week 8 with a topical, 50% of patients achieving clear or almost clear skin versus 25% of placebo-treated patients. And so we have, for the first time, really quite dramatic efficacy of a topical, of a non-steroidal topical. Baricitinib, so now oral JAK inhibitors. So this is one of a few oral baricitinib clinical trials, phase 3, and we see here about 17% of patients achieving clear or almost clear skin over 16 weeks of treatment versus 5% of placebo-treated patients. And then over here we see the effect on itch. And everybody familiar with this space will understand or know that JAK inhibitors provide incredibly rapid relief of itch, and it's really one of the points that they stand out on in AD. And then abrocitinib, again, phase 3 data now down to age 12, same group of patients, moderate to severe AD. And we see here, looking at 2 doses of this drug, 100 milligrams or 200 milligrams, we see out at week 12, 30 to 50% of patients achieving clear or almost clear skin. And then over here, again, look at this, 50 to almost 60% of patients having dramatic improvement in itch over that same period of time. And just in the interest of time, we're not going to talk about comparator data with dupilumab, which of course now is the standard of care in atopic dermatitis. But this data, there was a really great New England Journal of Medicine paper just published a few months ago comparing head-to-head abrocitinib versus dupilumab, and the results are very similar. Then upadacitinib, again, phase 3 data, 12 years or older, and we see modestly increased efficacy over abrocitinib. And here at week 16, so a little different time point than abrocitinib, we see, kind of 45 to 60% of patients achieving clear or almost clear skin. And then over here again, a dramatic rise in relief of itch. And you see it kind of falls down a little bit, but the idea is somewhere in kind of the 50 to 60% range, proportion of patients having this dramatic improvement. And again, we have a paper just published in JAMA Dermatology a month or 2 ago comparing upadacitinib and dupilumab, showing the same efficacy of upadacitinib, highest dose. They didn't test the lowest dose of upadacitinib, but the highest dose of upadacitinib has the same efficacy as dupilumab. So this is great, right? We have at least 2 drugs that have similar efficacy as dupilumab in atopic dermatitis. So now alopecia areata, the numerous ways this disease can appear. And it's kind of fun to think about where we've come from in terms of understanding the disease. There's a very long history that, is perpetuated. We heard about this earlier from Natasha, right? Even today, we're still wondering about the role of stress, but certainly in the 1900s, paper after paper claimed that patients' nerves were driving their disease. And then there was a seminal discovery of the hair bulb surrounded by a lymphocytic infiltrate, which ultimately led to the concept of treating the disease with prednisone and cyclosporin and other traditional immunosuppression. Then the seminal discovery of the innate and adaptive immunity being involved in pathogenesis, which ultimately led to the seminal 2014 paper, which is shown here. And this work kind of led to this model implicating IL-15 and other gamma chain cytokines and interferon gamma as being the drivers leading to this T cell proliferation around the hair bulb. And you see that IL-15 signaling is mediated by the JAK-STAT pathway, and interferon gamma signaling at the hair follicle is mediated by the JAK-STAT pathway, and so that led to the potential that this same class of medicines that we just reviewed in atopic dermatitis might be effective here. So these are the trials for which we have a lot of data. And so starting off, we have ruxolitinib cream. So again, we saw, it's kind of fun, right? This section of the talk parallels the last one. So ruxolitinib cream in a phase 2 randomized double-blind placebo-controlled trial in AA, severe AA, greater than or equal to 50% scalp hair loss at baseline. It didn't do anything. And so that could be because of vehicle and penetration, or it could just be because topicals don't work. Now looking at oral JAK inhibitors in AA. So ruxolitinib, previously called CTP-543, a JAK1/2 inhibitor, very similar to ruxolitinib, just a slight chemical modification with deuterium. And we have, looking at SALT 75 and SALT 90, so 75% or 90% change from baseline. So think of people having no hair and then ending up, in this case, at 24 weeks with 25% or less scalp hair loss. And you see 29 or 40%, 42% of patients achieving this dramatic reduction in hair loss at 2 doses of this medicine. Ritlecitinib, so now this is super exciting, hot off the press, just presented at the EADV a few weeks ago, phase 3 clinical trial data. This is a JAK3 TEC inhibitor, and the proportion of patients achieving a SALT score less than or equal to 20. The primary endpoint was at 24 weeks. The trial went out to 48 weeks. And so we have, for the first time, a lot of patients, right? Over 700 patients in this clinical trial. So not phase 2, 120, but over 700 patients. You can see different dosing regimens, and you can see that at 24 weeks, depending on the dose, you have somewhere in the 20 to 30% range of patients achieving this very low SALT score. And at 48 weeks, it rises to somewhere in the 30 to 40% range. And so really exciting to see, for the first time, very high quality data showing efficacy. And now at the same time, EADV, just a few weeks ago, we have phase 3 data of baricitinib, which is a JAK1/2 inhibitor. We saw data for baricitinib in AD in the last section. And we see here, again, super big data set, 700 patients in one trial, 500 in another, so now 1,200 patients over 2 clinical trials with the same, essentially the same data in both. And we see at either dose, we get somewhere between 22% and 35% of patients achieving this very low SALT score over 36 weeks of treatment. It's interesting also to think about, for people who want to think about kind of the disease nuances and mechanism of action of drug nuances, you know, baricitinib has modest efficacy in AD, and so I think a lot of people would have predicted that it would have very modest efficacy in alopecia areata, but it has great efficacy in alopecia areata. And so we don't know everything that we think we do about these diseases, and we don't know everything that we think we do about JAK inhibitors and their mechanism of action. And these are just before and after photos. These are patients in my clinic. This is a common event. They didn't have to dig deep to find these photographs. For women in the last slide, for men in this slide, you can see JAK inhibitors do nothing for androgenetic alopecia. Natasha actually just published a second paper showing this, which I think is really nice because, right, a lot of people are seekers right? And they're looking for answers for their androgenetic alopecia, and we should not ever be telling people that these medicines work. If they did, I would be taking. In fact, I would have enough hair that my kids wouldn't make this comment just by virtue of inhaling the breath of my patients, since I'm around this stuff so much. So I'm going to wrap up here. I think that this is kind of a fun place to think of the marriage of atopic dermatitis and alopecia areata. So alopecia areata comorbidities, and we've already heard about this, right? There's comorbid autoimmune disease, thyroid disease being the most prominent, and then there's comorbid atopic disease that we just heard about. And in my mind, it's really fun to think, AA is an amazing disease to think about polyautoimmunity. It is a very common disease found in polyautoimmunity, and indeed also found in multiple autoimmune syndrome. And so that led me to think of this Venn diagram, where here you have AA, and then you have the numerous comorbid diseases that commonly occur in these patients. And ultimately, right, the co-occurrence is related to shared genetics and immune pathways. I think that's necessarily true. And so when you think about treating these patients, and you think about what's at the center of the Venn diagram, what has been shown to treat every one of these diseases? Corticosteroids, obviously. JAK inhibitors, there's really not much else. You might put methotrexate there, you might put cyclosporin, but really high-level data, JAK inhibitors. And so I think it's fun to think about, for all of us to be more clever physicians, more clever dermatologists, right? We kind of have to step out of our silo of hair or our silo of skin, and we have to ask more questions about our patients and their health, because I think thinking about our patients with alopecia areata, with comorbid disease, JAK inhibitors offer the possibility of making them better in more than one way. I think that we can make their alopecia areata better. We can make their atopic dermatitis when they have comorbid disease better at the same time. This was just a retrospective series of patients in my clinic who have AA and IBD that I treated with tofacitinib. The vast majority, their IBD went into remission with tofacitinib treatment. And so again, we have one medicine or one class of medicines to make a patient better overall. And so in summary, JAK inhibitors are small molecules. They're cytokine modulators. They're not nearly as specific, obviously, as a monoclonal antibody, but I think that's also the beauty of them. When you don't want something utterly targeted, JAK inhibitors are a great way to modulate cytokine signaling. They're important drivers. These cytokines are important drivers of AD. They all signal through the JAK-STAT pathway. These are important drivers of AA, but also vitiligo, sarcoidosis, granuloma annulare, and other diseases. And so it's not surprising then that JAK inhibitors are efficacious across this whole spectrum of disease. And, just a little food for thought, I really think that this is the most interesting class of medicines for the patients with polyautoimmunity. Thank you very much.